Communication matters. That's why at Medical Service Company, we provide timely outreach to every patient and referral within 24 hours of receiving a new CPAP order. As the MSC intake team contacts the patient to schedule their setup, we offer a variety of scheduling options. MSC recognizes that the pandemic has presented varying levels of comfort among healthcare providers and the public alike. MSC strives to ensure that each patient feels safe and comfortable during their setup appointment. MSC scheduling options include an in-person appointment, video appointment, and telehealth appointment. Over the course of the pandemic, MSC has completed over 30,000 virtual appointments with great success. This has allowed us to care for thousands of new patients across the nation while boosting industry-leading compliance rates. If you have a patient in need of an appointment in person or virtually, visit medicalserviceco.com.
Good afternoon and welcome back. I hope you're enjoying this day of sleep and respiratory education. This afternoon, you will hear lectures specific to sleep based on your enrollment in the sleep track. We have speakers lined up to provide sleep-specific lectures designed to further enhance your knowledge in sleep medicine. Dr. Kingman Strohl will kick off the afternoon for us, and he will be speaking on sleep health, can it be measured? Dr. Strohl is a world-renowned sleep physician and speaker with a true passion for what he does. He is a professor of medicine and physiology and biophysics at Case Western Reserve University in Cleveland, Ohio. Dr. Strohl is also the director at the Center for Sleep Disorder Research at the Lewis Stokes VA Medical Center and the director of the Case Fellowship in Sleep Medicine. Dr. Strohl practices clinical sleep and pulmonary medicine with specific expertise in respiratory control, mechanics, pathophysiology of gas exchange, and clinical drug and device trial design. As you listen to the upcoming lecture, feel free to submit your questions to Dr. Strohl under the Engage tab. And don't forget to complete and submit your evaluation for each lecture.
Hello, and thank you for the opportunity to speak to you today. I'm Kingman Strohl. I'm the director of the Case Fellowship in Sleep Medicine here at University Hospitals Cleveland Medical Center. It includes the VA Medical Center, Case Western Reserve University, and Metro Health Medical Center. Today's topic is going to be sleep health. Can it be measured? And we're going to go through the idea that there is something called sleep health, that it would be a metric that would be useful and as useful as temperature or blood pressure, and be able to improve the health of the community and of the population. Disclosures, I have nothing relevant in this talk, but I do have support from the NIH and Department of Defense, Metrics phase 3 trial, writing groups for Inspire and GS Pharmaceuticals, and consultant for 2 pharmaceutical companies, and a section editor for UpToDate, Medscape, and Merck Manual. So what's the economic impact of sleep unwellness, that is unhealth, of disease? Well, Rand Corporation says it's about $41 billion a year to sleepiness and fatigue. National Safety Council estimates that a typical employer with 1,000 employees, and UH has something like 10,000 employees, can affect to lose more than $1 million a year to fatigue, and about $250,000 due to absenteeism, and $750,000 due to what they call presenteeism. That is, you're sleepy, you're sleep deprived, and you're there at work, but you're not up to par. Now, therapy cost is estimated to be more than $7 billion a year in insurance cost, and about $2 billion more over-the-counter aids for things like insomnia, for sleep aids, for sleep disordered breathing, earplugs, etc. So the objectives of this talk are to define sleep health and wellness, and to define it in such a way it could become a policy goal, to recount the history of sleep medicine health metrics, and to list examples of deployment of a sleep metric. And this story is just beginning. It doesn't have a complete end to it, doesn't have a definitive answer, and I want to start the process. So what is health? Well, in the broadest sense, the health is the outcome of a group of individuals, including the distribution of such outcomes within the group. So think of this, blood pressure health. It would be the distribution of blood pressures in the population and those that are associated with health and those that are associated with disease. That distribution within a population determines where you should focus your resources. And it influences your personal, social, economic, and environmental factors. Policies and interventions then flow from this observation. And blood pressure is a very interesting one because generally people can't feel it. They don't really know whether or not they are a hypertensive. And then they go and they take medicine because people have shown that reducing your blood pressure from higher values to lower values improves cardiovascular health and outcomes, improves the health of individuals, and prolongs life. So defining sleep does not really generate a sleep metric. So I'm a physician. I think of sleep disorders and sleep medicine. And one of the groups that started sleep medicine is Mary Karskadon and Bill Dement. And they said, well, sleep is recurring, reversible neurobehavioral states of relative perceptual disengagement from and unresponsiveness to the environment. Sleep is typically accompanied by postural recumbrance, behavioral quiescence, and closed eyes. I don't think that is a good definition that we want to use for health. I think it's too wordy, as well as it really doesn't capture what would be a healthy sleep. But the National Institutes of Mental Health is really no more useful because it really talks in physiologic terms that sleep and wakefulness are endogenous, recurring behavioral states that reflect the coordinated changes, et cetera, et cetera, et cetera. It does identify, though, the pieces of sleep health that are important. That is homeostatic and circadian processes, regulate the propensity for wakefulness and sleep. But if I go out there and have a metric, imagine what it would be like if I could say, well, how well do you perceive your propensity for wakefulness and sleep? So you can see that we really need to start to talk about sleep in ways that define it for individuals so that they can identify their own sleep health and therefore contribute to the collection of group data in what is sleep health. So how do you define it for this purpose? First, medical is the absence of abnormal values of behavioral biochemical domain. That's like blood pressure. WHO, though, takes a macroeconomic metrics of health. That's the World Health Organization says we want to lower blood pressure. We want to lower hemoglobin A1C. 3 is an environmental or adaptive model, an evolutionary fitness that a certain particular trait is no longer successful for reproduction. And so wellness probably is the best domain to think about sleep. That is a role performance model, being able to do things. So if you don't sleep well, you can't do certain things. And if you do sleep well, you can do other things well or more optimally. But sleep is really multimodal. There's a sleep need, just like there's appetite, there's food, and there's food. You have to have a circadian, a need for sleep. That is, if you don't get enough sleep, you need to get more. That's like nutrition. There's a behavior. What that is that how we sleep and where we sleep and how we time our sleep and how much sleep we get often has behavioral domains, such as, well, I'd like to stay up and watch Johnny Carson. That was the early forcing of people to stay up. And then I have to get up to go to work. Those sorts of things restrict sleep and make people sleepy. But we also want to have something that is an outcome. That is, the outcome is the result of a number of attractors and distractors from sleep. What do I mean by that? Well, attractors for sleep is a comfortable place, comfortable bed, quiet, cool, and without stress. A distractor, however, would be TV, lots of noise, living next to a subway line, having a airport nearby, those sorts of environmental distractors. Or it could be just anxiety and stress because of your environment. So the models of health we've talked about a bit. They can be medical or clinical, the absence of abnormal values. World Health Organization wants a macroeconomic health metric. And there can be metrics that follow environmental and adaptive models. But really, we're interested in wellness, or the role performance model for sleep, being able to do things. If you're sleepy, you don't perform as well. If you're awake, you perform better. And so what are those things that create the ability to function both personally and in your social interactions optimally? So a metric can tell us how an individual or population is doing in regards to sleep. A metric could estimate the range and degree in a population, could give you a set of normal values. Metric could provide targets for health promotion and prevention activities. So you could move from one spot to another, giving certain sort of either environmental or even social sorts of interactions and learning. And it could be useful for practical research. Too often we sort of focus on the disease, that is sleep apnea, and the treatment that we have for it, say CPAP, but we really don't know if the broader picture of how do you sleep improves. Or we give a sleeping stimulant in those people with narcolepsy, and we want to know how their sleep is in general. Has it improved? Has their wakefulness improved? And we want to have a broader view then of the sleep wellness domain. Now, the first national metric was really in 1979. It was reported time asleep. And it's interesting, the American Cancer Society surveyed about 1 million family and friends aged 30 to 103 years. They did a 6-year follow-up. They found that men slept less than 4 hours, were 2.8 times as likely to have died as men who reported 7 to 8 hours of sleep. They found that women sleeping greater than 10 hours were 1.8 times the mortality of those who reported 7 to 9 hours of sleep. And they found that sleeping pills made no difference. Now, this was in a time in which sleeping pills were fairly common. This was 1980s, 1970s and 80s. But this was a metric then, sleep duration. So let's look at sleep duration a little bit. So on the left is the relative risk of mortality according to the 24-hour sleep duration. And on the right is a little more granular example, but let's look on the left here. So this is relative risk, and it goes from 1, which is nothing, to 2, which is fairly high. And you can see it has a U-shaped sort of pattern to it. And that those people that sleep around 7, maybe 8, 6 to 8 hours, they have the lowest mortality risk. And that as you go less than 6 hours, there's a slight increase in mortality. But as you go and proceed more towards 9, 10, 11 hours of sleep a day, that the mortality increases. Now that's an entire day. That doesn't necessarily mean you get all these 7 hours at the same time. There are many pre-industrial societies that have 2 or 3 sleeps a day, that break their night sleep into 2 sleeps, or break their sleep into several pieces because of the environmental factors of it being too hot to work during the day. On the right is the effect of this same sort of sleep duration, whether or not you have diabetes in blue, and diabetes in red, that is the triangles with the red and the standard deviation were red in diabetes, or blue, no diabetes. And it seems to hold true. Diabetics have a higher ratio of dying, but they do in general, given any given sleep duration. So I think that this sleep duration is a pretty good metric. Now, why do we want to use these metrics? Well, there is this thing called healthy people. We have the NIH and the CDC mandated that there be metrics for health in the United States. There was a 2000 metric, there was a 2010 metric, there's 2020 metric that's just being analyzed. And the one in 2010 had a survey, had little sleep in it, but they put 6 sleep disease questions. That is snoring, insomnia, etc. We did an analysis of that particular data set and found that resistant hypertension showed a positive association with lower socioeconomic status, but a negative association with self-reported snoring. We were very disappointed because we thought that resistant hypertension would really be related to snoring and could then be another healthy way of looking at why we should stamp out sleep apnea in our time. But obviously there are other factors that result in resistant hypertension, primarily socioeconomic status. The positive outcome was defined by sleep duration as defined by the person. So sleep duration was an important factor. So the CDC had measured this sleep duration, and on the left is a results of those prevalence of short sleep duration of people sleeping less than 7 hours a night for adults age 18 years. And on the left is that by state. So the state of Ohio has about 38 to 44% of the population sleeps less than 7 hours. And the lowest are those in the western states. You know, look at Idaho, 25 to 31%. But then what's interesting is that on the right is that by county. That is the county of each state. So on the so a macro is the state level. On the right is the micro level or the community level, and you can see where these particular short sleep periods are clustered around cities. They're clustered in some of them in rural areas in particular, and so those would be the places to try to identify short sleep. Unfortunately, they didn't ask about long sleep. They did do an association between less than 7 hours of sleep, and this was the percent of people with these conditions that got less than 7 hours of sleep. And this is a chronic kidney disease, stroke, COPD, cardiovascular disease, and arthritis in particular was the one associated with less than 7 hours of sleep. We can see that duration and illness, sleep duration and illness occur together as they probably should. Arthritis, aches and pains probably are the ones that should give you short sleep, but that depression, asthma, diabetes are other diseases associated with markers of short sleep. Now, sleep deprivation affects your health, and there are now a CDC public message that comes out of that particular metric of sleep duration, with impaired cognition, higher levels of anxiety, stroke risk, increased risk for diabetes, symptoms of depression, increased risk of breast cancer, in particular heart disease and weight gain. So the public messages about sleep are derived from data that are the consequence of individuals at a policy level, at a CDC level, thinking that sleep is important, asking those questions, finding that those results are relevant to the health of the nation, and then trying to make an impact on it by recognition. In this instance, it's recognition of illnesses and the association of these conditions. Now, it's bidirectional. That is, that short sleep can increase aches and pains. It can increase glucose levels. It can increase insulin resistance. It can lead to cardiovascular problems. But the idea is that you have to look and find these through surveys, through metrics, and through ideas that that come out of those metrics for public health. So what are normal sleep durations? These are the recommendations for the National Sleep Foundation. These recommendations of young adults being 7 to 9. This particular metric here is important. You notice that there's higher levels in school age and preschool and teens than we generally find in our teenagers and sometimes in our school age kids. These are the recommendations that people have found that this duration of sleep over an entire day leads to better performance, better cognition, more ability to react, faster reaction times, and ability to control your emotions. There are comorbid behavioral traits with insufficient sleep, and that is that those that have insufficient sleep, that is the ones that are gray, and the sufficient sleep, which are black, that the gray lines are that, I'm sorry, the ones that are sufficient sleep are in gray, those with insufficient sleep are in black, and those are the black line here, for instance, fair, poor general health, have generally insufficient sleep. Frequent physical distress is also a higher percentage of insufficient sleep. Frequent mental distress, higher insufficient sleep. Frequent depressive syndromes, higher insufficient sleep. Frequent anxiety, frequent pain, and frequent activity. So these are the sorts of things that come out of these national surveys. Now you might say, well, I kind of know this already. I could have predicted this. But these surveys include a representative sample of the United States and sort of put into numbers what people generally think is happening and get targets so that those people with anxiety, one of the things that you might want to target is their sleep health and to be able to take care of their anxiety. So Healthy People 200, the goal to 2020, Healthy People 2020 was to reduce sleep disorders to improve health, productivity, and quality of life. It's a 10-year agenda. The objectives are to increase medical evaluation of individuals with symptoms of obstructive sleep apnea, reduce vehicular crashes due to drowsy driving, and increase rate of teens and adults who get sufficient sleep. So what you see is that metrics from 2010 got put into the goals for 2020, and that these are still fairly disease-oriented in terms of sleep apnea, but then they also talk about the consequences of sleepiness and the consequences of insufficient sleep. So societies at that time were asked to say, well, since we only have these metrics and we know that sleep is more than just sleep apnea, more than just insomnia, more than just other comorbidities, can you define healthy sleep? And the ATS, American Thoracic Society, the American Academy of Sleep Medicine, and the National Sleep Foundation came out with healthy sleep recommendations. This was at the request of the NIH that said that the CDC needed these particular metrics to design Healthy People 2030. So that's where we're in right now. But duration is too simple, way too simple. And you know that. Individual differences, sleep-wake traits, subjective sleepiness, affective temperament, culture, race, gender, physiology, which the doctors all think about, where we all look at sleep states, we all think of those things. Psychosocial factors, poor sleep hygiene, cost-benefit analysis, cultural factors, day-night schedules, performance markers, task, type, well-being. So the workers going into the Mercedes-Benz manufacturing have to do a reaction time test for about 5 minutes, and if they fail that, they aren't allowed to work in the plant that day. They found that people who come sleep deprived or hungover or have a cold and can't think straight, or taking medicines that they may have been even prescribed for pain, and they don't perform quickly in terms of that task, or really make more errors in the manufacturing plant, and those errors cost more than just sending them home for the day. So these are the sorts of things that impact upon our society. So the SRS, Sleep Research Society, the AASM, American Academy of Sleep Medicine, in 2013 at a consensus conference, their goal was to promote improved sleep. And I'm going to go over some of their metrics that they thought were important. Their objectives were to increase medical evaluation of people with OSA. Okay, that's self-serving. That's really, we want to see more people because they have sleep apnea. Now, there are lots of sleep apnea patients that aren't diagnosed or treated. We know that, but the awareness of sleep apnea is now what it was, is much higher than it was about 20 years ago. Reduced vehicular crashes, increase the rate of teens that get sufficient sleep. So this is the journal, Clinical Sleep Medicine. This is a journal article, development of it, and I'll summarize it here for you. They had tagging survey questions: duration, hours of sleep. They want duration either numerically or categorically. What that means is you say how many hours, or categorically between this and that. That is 6 and 8, and then 5 and 6. That would be a category. Numerically, it would be by half hour. Quality, experience in sleep, as what's your subjective sleep experience, difficulties getting to and staying asleep, interruptions, wake time in bed. Satisfaction, adequacy of sleep, sleep directly, alertness. And then they put in obstructive sleep apnea risk. I mean, these are a bunch of doctors, mostly PhD people working in the field of sleep, so they think about sleep apnea a lot. So these were the standardized questions. These are not the final ones, but these are the ones how you develop them. This is how you develop this. During the past 30 days, about how many days have you felt you did not get enough rest or sleep? That's not a bad question. On average, how many hours of sleep do you get in a 24-hour period? We already talked about duration being an important factor. Do you snore? During the past 30 days, for how many days did you find yourself unintentionally falling asleep during the day? And during the past 30 days, have you ever nodded off or fallen asleep, even for just a brief moment while driving? So they recommended that duration be how many hours of sleep do you get in a 24-hour period? And you enter the hours of sleep, your satisfaction. How many days have you had trouble falling asleep or staying asleep? What's your alertness during the past 2 weeks? For how many days have you found yourself unintentionally falling asleep during the day? And OSA risk, that's the stop bang questionnaire. So they really couldn't help themselves. They put that in there, and they didn't ask about insomnia, really. They didn't really ask about a disease. So it's an odd one for people to really put out there in the community. In parallel, however, there was a Dr. Vicey in Pittsburgh had this article, which I recommend reading because it's very comprehensive of why we need a metric. It's called Sleep Health. He has a particular metric called Are You Sated, which is copyrighted, and therefore it's difficult to kind of deploy. Generally, it could be, but there is still needs a lot of work on trying to find the optimal sleep metric, and this is some of the words from his article here. Sleep health, can we define it, and does it matter? Sleep health is a multidimensional pattern of sleep wakefulness adapted to individual, social, and environmental demands that promotes physical and mental well-being. Good sleep health is characterized by subjective satisfaction, appropriate timing, adequate duration, high efficiency, and sustained alertness during waking hours. The Are You Sated has regularity, satisfaction, alertness, timing, efficiency, and duration. Really doesn't matter about whether you have this disease or that disease. It doesn't ask about disease. It's a self-reported scale. It has 5 dimensions of sleep, and 4 of the 5 dimensions are rooted in observations of behaviorally using actigraphy and physiological PSG level analysis. You don't need those, but they've correlated with it. And there are several studies that now suggest that these types of questions are very important to get people to answer in a way that would be predictable and of something happening with their sleep. And that would be a model for looking at how we treat patients and how we teach society how to sleep better. So do they predict? They predict all-cause mortality in older men. This is interesting. This is duration, continuity, timing, sleeping, alertness, quality, rhythmicity, regularity, and composite. You can find out what this particular multivariate analysis could give you, but what it ends up by showing is that these descriptive analyses can be applied to data sets that we currently have that predict mortality. And so these are the sorts of mapping of all these dimensions. Duration, ease of falling asleep, good or poor sleep, ability to maintain attentive wakefulness, duration, continuity, efficiency, sleep satisfaction, alertness, duration, sleep quality, sleep satisfaction, alertness, and OSA risk, sleep duration, sleep satisfaction, quality, alertness, and OSA risk. And so you can see how these things start to map together, and that people are now trying to say what collection of these things confer the greater risk. Well, let's give a couple examples now that we have an understanding of the types of questions and how they're asked about sleep health, and whether it makes whether people have found that it makes difference. Examples: WHO lists smoking, alcohol intake, diet, physical activity as key modifiable risk factors that could enhance health and prevent non-communicable diseases. There are now a number of groups that have looked and reanalyzed existing data to say about sleep health. So we want to be able to say, does sleep health map to those particular risk factors, and are they modifiable? I think they are. On the left is the SATED score, and then on the right is sleep duration and the number of reported chronic diseases. So the scale on the horizontal axis is the same. It's the SATED score. Its maximal is 10, which is best sleep, and 0, which is the worst sleep. The number of blue dots in there and the density of the dots show the number of individuals. And on the left-hand side is the number of chronic diseases. So as the number of chronic diseases goes up, the sleep score goes. Sleep score is more towards 0. And when there are less comorbid conditions in a population, the sleep score is better. Sleep duration maps to a similar sort of metric, and that the number of chronic diseases is high in short sleepers and long sleepers. But duration itself can be molded into a series of questions that give you a kind of a temperature. That is the SATED score is a temperature of what sleep health is in an individual and in a population. Now notice it's a pretty messy one, and that's really what I'm interested in developing, is a sleep health metric and finding out how people that I think should have poor sleep because of their age, their comorbidity, and their treatments. They should have poor sleep, but yet they sleep well. I'm interested in knowing how identifying those people and figuring out what they're doing. So the ROC between the SATED score for sleep duration, self-reported health status, the ROC curve really sees how much of the data an outcome is captured by a particular metric, and the more under the curve, the area under the curve, the dashed lines are those of the sated model, and the solid lines are sleep duration. The sated model captures more information about outcome or protection or association. So the correlation among risk factors for poor perceived health adjusted for age, gender, education level, number of comorbidities and health status, poor sleep health, poor diet, and low physical activity. So each of these things that are in WHO as being modifiable risk factors are now linked to some one degree or another to poor sleep health. So on the right is the area under the curve. Sleep health is it's a little hard to see, but it's one of the solid lines here. It's pink. It's towards the black line, and the black line is the entire model with all those WHO risk factors. Simultaneous consideration of multiple sleep factors. And so these are all the multiple sleep factors. And as you add 7 sleep questions or 7 sleep questions versus looking for the extremes, you find that the predicted for the variable importance and random survival force, this is simultaneous considerations, is that if you ask several different questions about sleep, it has greater ability to capture the morbidity in the population than if you just ask one. And the regularity, satisfaction, and alertness correlate with health. Duration correlates with the timing on actigraphy. Apnea hypopnea index loads with inefficiency and irregularity of sleep. And 30% of the variation is explained for any one given physiologic variable consistent with the multidimensional nature of sleep health. So it has an internal validity, and it has a validity in mapping towards other diseases. It does not tell you what disease a person has, but it tells you that the sleep health that's there is either pretty good or pretty bad, and you can follow it with things like drought, with global warming, with food scarcity, with medical systems. You could sort, and with things like cultural upheavals and wars. So sleep health and prostate cancer. Aggressiveness is categorical analysis of the sleep variables. Extremes of distress correlated with a higher cancer grade. Quality, trouble falling asleep and trouble staying awake. It's trouble falling asleep. Quality and trouble staying asleep at a higher odds ratio of progressing faster in your prostate cancer. But trouble staying awake during the day was protected. I'm sorry, it says but it's the day. It was protected. Now, what that means is that we don't understand everything that comes out of this. So, summary: a metric evolution is important. We think there are 7, 9, maybe domains. They can be collapsed to 5 domains, whether that's appropriate. They may identify phenotypes, that is, average sleep, heightened sleep propensity, insomnia. Maybe these sorts of things go out, but the major purpose of this metric will be to try to establish what healthy norms are, and then whether or not we can identify how we can use this metric to track treatments like CPAP, like insomnia treatments, like restless legs treatments. So it's a starting point of our program. We want to deploy this in a post-COVID long haul clinic. We want to use as an outcome for any sleep patient. And we want to look at different non-sleep populations like cystic fibrosis, like diabetes, like heart failure, to map to these particular metrics. Now, we think that the subjective reports are, and we're going to start with how many hours do you sleep per day? Are you awake less than 60 minutes during this sleep period? Are you asleep between 2 and 4 a.m.? That's capturing circadian changes in sleep. Satisfaction, are you content with how well you sleep? Wake time sleepiness, do you stay awake without dozing? And regularity, do you have habitual times of when to go to sleep and when to wake up within 1 hour? Now, our questions map to these other questionnaires. It doesn't have sleep apnea in it, but it asks 6 questions that sort of wrap around duration, quality, satisfaction, and alertness. We don't know if 6 questions is enough, and we're going to take a step back and develop this further behind the scenes. But we're going to deploy it first in the long haul clinic, long haul COVID clinic, and we're going to deploy it in the sleep clinic to try to track our overall quality of sleep medicine. That is, do we make a difference in the diagnosis and management of sleep diseases in terms of sleep health, sleep wellness? So I want to end up here by talking about once you have a metric, you can then start to think of prevention. And the metric that comes to mind is that of blood pressure. A metric also is probably body mass index. But let's see what that means in the future. So if I can envision having a pretty good metric that I could apply to a group of people, can I use that to then say, okay, can I get insight into prevention of that particular disease, in particular sleep apnea? So primordial prevention is prevention of the emergence or development of risk factors. So if I wanted to stop in countries or populations in which they have not yet appeared. Now, what does that mean? Well, at one time, we didn't have a lot of sleep apnea, or we had sleep apnea, but we didn't have as much as we have today because obesity occurred. So can we go in there and try to find out what sleep health is like, what sort of sleep problems are there, and how do they change with things like food availability, which is one reason for why China is getting more obese. Everyone blames it on Kentucky Fried Chicken, but their standard of living has increased. And when the standard of living increases, you can buy more food, your taste can change, and that is the consequence. That has as its consequence obesity. Primary prevention, action taken to prevent the onset of disease, which removes the possibility that disease will ever occur. Well, one of the things in sleep, in childhood snoring that they're using is rapid palatal expansion to try to increase the size of the nasopharynx. And there is some consideration that particular approach will reduce the amount of sleep apnea at 30, 40 years of age. I don't know if it does, but in terms of sleep health in childhood, is that predictive of sleep health in young adulthood? Or is young adulthood predictive of problems later on? And can we prevent those things? Secondary prevention is that which halts the progression of a disease. And that would be early detection of sleep problems, a fall in sleep health that occurs as you go to your primary care physician or your gynecologist or orthodontist. I mean, those are people you see on a more regular basis in your 30s than you see a primary care practitioner. So can you use these on a uniform basis? And tertiary is then all measures available to reduce or limit impairments or disabilities. That's what medical stuff does. That's what I do. Minimize the suffering caused by patients, adjustments to irremediable conditions. That is can we improve sleep health in patients with cancer? Can we improve sleep health in patients with depression? Can we improve sleep health in conditions where there's chronic arthritis or other chronic conditions? So that's why you need to have a metric. So the objectives of this talk were really to define sleep health as a policy goal. And I know it's very wordy to talk about it that way. A lot of terms, a lot of definitions, a lot of ways to kind of, in some ways, try to justify it. But that intellectual and basis, the data that are needed to define what the first questions are important to understand and why you want to define this particular metric. Recount the history of the sleep health metric, going first from duration, the earliest one, to now a multi-dimensional aspect of asking about your sleep. And then to list examples of the deployment of a sleep health metric, that it could be used. I think very intriguing that if your sleep health at particular time 0 in a diagnosis of a cancer determines to some degree, even 10 or 15% of where you'll be in a year would be a very interesting observation. It already has been made. There is some work now being done on whether your sleep health it influences your hemoglobin A1C in diabetes management. There is some interest in doing whether sleep health is a factor in the decline in FEV1 in patients with cystic fibrosis. There is a idea that maybe it is a measure that correlates in some ways with self-efficacy and your ability to take your medicines on time. And it may be an index of impending frailty in the elderly. So I think that that's the utility of having a sleep metric. And that's really, it's more of a promissory lecture than it is a definitive statement. And if I sound like I'm sort of waving my hands, I really am, because this is a new field. And I want to thank you very much for listening to this and be glad to answer any questions.